Are people in?
Yeah, we're getting yeah, they're quickly coming in. We're at 10, but the numbers keep coming up.
Okay. Now you're going to show me, or how are you going to do it? I can just see the session. I can't see the actual slides, but this is the recording that you'll be putting on, right?
Yes, correct.
And I don't want Dr. Casey. This part shouldn't go on. This should be just me and then Dr. Nash. Okay.
Yeah, I stopped my recording on my end, so they should be able to see you, and then once you're done, I'll be able to go back to that recording.
Okay. Okay.
And we are currently at 18 participants.
Okay. Where should, can you see me?
I can't see you, yes.
It's just in the top. It's just at the top. Is it showing you on the full screen?
Yeah, on my end, on my Zoom, I can see you, and it's right now just you and me because we are the only two hosts. Everyone else, like, you won't be able to see them, if that makes sense, because they are panelists.
Okay, good. How many do we have now?
We still have 19.
Okay. Let's give it one more minute and then we'll get started.
Okay.
They don't have to sign in, do they?
They just through the link that we originally sent, they should be able to get access to this.
Yeah, just send Brian Amy a note. He just put in a note. Do we have to sign in? You say no, just go directly to the Zoom. You want to send it to me?
Gotcha.
Send it to him, please, real quickly.
Yep.
Good.
Also, too, before we get started, if you can do me a huge favor too, the link that you used to get in this exact meeting, you should have got an email right before you got in. Could you copy and paste that and put that in the chat for me?
Let me just see. I've got to get out of it first. Let me just hold on a second. I got to go back to my emails. No, I don't have it. I'm sorry.
Okay, that's okay.
You're gonna have to put it in. I don't have it. Let me see. Let me see if I do have it. Here, okay. No, I don't have it.
That's okay. I can get it too. But whenever you want to get moving forward too.
Okay, I got to go ahead. I got to get my screen enlarged, and now I can't do it. Okay, we'll go ahead and get started. Good afternoon. I'm Dr. Dan Westfall. I'm the president of the American College of Medical Quality, and I would like to welcome each and every one of our participants for our first meeting that we've had. It's offering CME and CEUs, and we actually have had a very robust discussion internally about how we'll be able to provide CEUs and CMEs in the future. Before we really get started with Dr. Nash's presentation, who, as you all know, has been a really good friend of the college over the number of years, I want to let you know that Dr. Nash unfortunately will not be available to answer any questions after the meeting, but you can certainly submit your questions in the chat. We can forward those on and then provide those out to the participants. We want to just also remind all of you of our upcoming virtual annual meeting, our virtual webinar, which will be basically 4 hours each day on October 1st and October 2nd, talking about healthcare equity, a new paradigm in medical quality. And we'll certainly encourage any of you that are on the call today and on the meeting that you would take a look at the website, see the exciting list of speakers that we have, and please register. So without any further delay, I want to also now introduce Dr. Nash. He's going to be speaking on the new normal for QI. What will quality leaders need to demonstrate a true IOQ in a post-COVID digital health world? So we'll go ahead and get this started, and you can go ahead and proceed with that if you would, Dan.
I just want to double check. Do you currently see a black screen?
Yes.
Okay, I'm going to go ahead.
President of the American College of Medical Quality. Welcome to ACMQ's 47th annual and first virtual annual Medical Quality 2020, ensuring quality in the era of digital health. What does ACMQ mean by the word quality? We abide by the 6 aims of the Institute of Medicine that came out of the Crossing the Quality Chasm report several years ago. That is, care that is safe, timely, effective, efficient, equitable, and patient-centered in no order of importance. These are the 6 aims that we will use throughout this meeting to help define what we mean precisely by quality through all 6 aims. You also hear the term digital health bantered around, and it obviously has gotten to mean a lot of different things to a lot of different people. In fact, we want to take into account these perspectives. It's not just about telehealth or EMRs. It's about a whole lot of things that are evolving in medicine and healthcare, including artificial intelligence, remote monitoring, social determinants of health, and other major issues related to digital health. Ultimately, we want to analyze the question of the impact on quality of digital health, or a term you'll hear throughout this meeting that we refer to as the IOQ. In other words, we have a lot of digital health out there, but what impact is it actually making? What does it matter? We want to get to the heart of this through these discussions. This is our master schedule. As you can see, we are going to have 2 sessions a day for the next 4 days. And just to be certain, the first session of the day will begin every day at 11 a.m. and end at 12:15 p.m. Central Time. So adjust your time zones, you East Coasters. And also, the second session of the day will occur from 3 p.m. to 4:15 p.m., also Central Time. And as you can see, each of these sessions will repeat themselves in the same time of day through the next 4 days. We will offer you on-demand recordings of each virtual Medical Quality 2020 session within 1 hour after each live session on the virtual Medical Quality 2020 website. So even if you're unable to make every live session, you'll be able to very quickly, soon afterward, access each presentation in a recorded fashion on demand through the website. At the end of this meeting as well, we'll also be offering you 10 hours of continuing medical education credits, and the presentation slides will also be available after session 8 on the Virtual Medical Quality 2020 website. I'm very pleased and honored to have our good friend and colleague, David Nash, Dr. David Nash, who many of you know is the founding Dean Emeritus and Granted Professor of Health Policy at the Jefferson College of Population Health. David is also the editor-in-chief of ACMQ's journal, the American Journal of Medical Quality. And David is going to talk about the new normal for quality improvement. What will quality leaders need to demonstrate a true IOQ, impact on quality, in the post-COVID digital health world. Of course, we'll be looking throughout this meeting through the other lens of what's going on right now with the COVID pandemic. With David will be two moderators. One will be Mary Wright Cooper. Many of you know Mary. She's the program director of healthcare quality and safety and associate professor in population health, also at the Jefferson College of Population Health. And Mary is on our board. Dr. Dan Westfall is also moderating from Florida. And Dan is a fellow of the American College of Medical Quality and holds the Certified Medical Quality Certificate from the ACMQ. Dr. Westfall is on the ACMQ board as well, has been part of the steering committee, and serves in Florida as one of the Humana medical directors nationally. A few housekeeping items before we move ahead. Many of you are familiar with Zoom, and what we want to highlight is two things. One is, for your questions, we want you to use the Q&A function on the left side. So enter your questions there. On the right side, that's for chat. We will not be monitoring that nearly as closely because the moderators want to get your questions out to David for discussion throughout this session. So please heed those two opportunities. In addition, you can get virtual live help at any time during live meeting sessions using the chat feature on the meeting's website, these blue buttons that are on the website that you can get through your links. And also, if you have additional questions or challenges or comments, please contact us at meetings@affinity-strategies.com during regular business hours Central Time. Lastly, we want to thank our sponsors for their support and involvement in this meeting. And we want you to take time to visit the virtual exhibit hall, and you'll be hearing more about this throughout the meeting. But please visit the exhibit hall and listen into what our sponsors are saying about the conference. So now I'm going to turn it over to David, Mary, and Dan. And David, we can't wait to hear what you have to say. Thank you very much.
Great. Well, first of all, Don, thanks so much for all of your amazing leadership, especially during your tenure as president, all the hard work that went into making this the first ever in 47 years ACMQ virtual meeting. Thanks to my amazing colleagues, Mary and Don, for joining me and all of the hard work that went into producing this. Special thanks to our sponsors who hung in there with us during the transition to being virtual, and to all the learners, all of our junior colleagues, our residents, house officers, medical students, and finally to all of our peers around the country who are carving out time in late August to get an update and to get to be together. So I'm just really thrilled to be a part of this. So special thanks to everybody. So, wow, I'm not wearing it, but I have my ACMQ 30-year pin, something that I'm awfully proud of. And I know that a bunch of other people have their pins as well. So this is a group that means an awful lot to us. And Don, as you noted, I've had the real privilege of being the editor-in-chief of our amazing journal, the American Journal of Medical Quality, and speak about impact on quality. I think through the journal, we've had an amazingly important positive impact on quality. Special thanks to Mary Cooper, who's been a great associate editor, reviewing articles, helping us especially with all of the learners who want to get their papers published. And over the last really 20 years that I've been at the helm of ACMQ, I think we continue to make a really important contribution. So ACMQ is on a roll. So look, there's no future in predicting the future. And like everybody else on this amazing conference, I've been sitting in my home office since that fateful Monday, March 16th. They closed Jefferson University and our college on Friday, the 13th of March, easy to remember. And I remember sitting in my home office on that Monday thinking, good Lord, now what? But I think we've all found a way to adapt and adopt to the situation. And what I'd like to do is give a very quick overview I continue to track the literature, talk to folks literally around the world about where our movement is going, what's happening. I have a couple of key articles I'd like to highlight, but I'd like to give a sort of a big picture overview of some really important publications that have come out literally in the last 6 or 7 months. Let's go through that. I'll try to weave the impact on quality, the IOQ, as we go through this. And then what I'm really excited about is the dialogue with Mary and Don, and we're just gonna have a great time. So in chronological order, let me tell you what I've been reading, and I'm going to use these 8 citations as a way to sort of describe where I think the world is going, and certainly what's happened while we've all been hunkered down during the pandemic. So back in January, late January 2020, when we were hearing things about Wuhan, but like me, probably not taking it all that seriously, I think the first article that I'd like to highlight and certainly set this up for discussion as well is a piece from the Harvard Medical School and Harvard Business School in the New England Journal. Details not important. Here's the punchline. The piece was asking the question, does quality improve as a result of all of the hospital consolidation, mergers, and acquisition? And like me, I come from now a 14 hospital system, and I'm sure like many of you, you're in a burgeoning system in terms of size. And so this combined Harvard Business School, Harvard Medical School piece by really well-known authors got an awful lot of press, including a major headline in the Wall Street Journal. Here's the punchline, and I'm sure you won't be surprised. It was, if you would, inconclusive and no real documented improvements in quality or safety. Let's do that again. No real documented improvements in quality and safety due to all of the industry consolidation just prior to the pandemic. We're talking about work that was done and finally published in late January of 2020. So I hope we're going to come back to this because you can't deny that consolidation is a really important trend. And post-pandemic, I think, and it doesn't take a genius to realize this, with losses in the hundreds of billions, with furloughs, and with our industry reeling from months of not being able to do any elective work and all of its implications, I think we're going to see additional consolidation. Therefore, any research that says consolidation doesn't lead to an improvement in quality, I think is really important in the post-COVID era. That's the first piece. Second piece, maybe many of you saw, and that is the May 15th, not too long ago, May 15th, 2020 HHS publication called the National Health Quality Roadmap. National Health Quality Roadmap, perhaps you've seen it. Official publication from HHS. I was all over this. What did it say? Well, quick summary, it says we need to focus on 3 areas. The governance for quality. So that's the leadership structure, the role of the board. I mean, these are gigantic topics, but I think still very pertinent today. So one is, what's the governance of quality going to look like moving forward? And then 2, the need for ongoing transparency in the data, and the need for measures that make sense. And I think that's the take-home message from the May 15th, our second paper, the May 15th report from HHS that said it's called the National Health Quality Roadmap. Why are those measures so important? Well, like many of you, I'm suffering from measurement, malaise, measurement mania. We have too many measures. And so my prediction in the impact on quality in the post-COVID world, we're going to need fewer measures that make sense to clinicians. And we'll come back to that. And I'm sure that Dan and Mary have questions about that. So second conclusion based on the second article, fewer measures in the post-COVID impact on quality world. Okay, third paper. I'm sure you remember this one. This is the JAMA paper from June 25th. From the Armstrong Institute, the amazing group at Johns Hopkins, which had been led by Peter Pronovost. But now the Armstrong Institute put out an incredible piece in JAMA, which really was trying to distill the lessons from COVID as it relates to the impact on quality. Let me give you a couple of take homes. So as Don already said in his opening, let's not forget, colleagues, crossing the quality chasm was 2001. We're coming up on the 20th anniversary of that incredibly important document. And basically, what did the observers and the folks from Armstrong say? Well, they agreed and said, look, we've got to reduce the measurement burden. We have to get beyond manual chart review. We have to reduce the time lag from evaluating the measures and feeding those measures back to practitioners. Certainly a big, big challenge. And something that I'm very excited about, and I hope we'll get to talk about, we need to take aspects of the incident command structure, more on that in a minute, a little bit more about that incident command structure. Maybe we could distill some of that, the daily huddle, closure of the feedback loop, the ability to follow a quickly evolving clinical situation by giving transparency and real-time feedback. So the Armstrong Institute leaders, June 25th, JAMA, our third paper, they said, we've got to be more agile and resilient. Boy, I sure agree with that. So as it relates to the impact on quality, agility, resilience, they got it right. Okay, fourth paper, July 27th in JAMA. Notice we're going in chronological order from January to the present. So the July 27th JAMA was a really interesting paper. This is also from our colleagues at Harvard, a national critique of hospital quality rankings. So they took, in the COVID era, what do national hospital quality rankings mean? Well, I'm sure you're not surprised to learn that we're going to need to change how we look at quality rankings. This IOQ, the impact on quality in the digital post-COVID world, what will we have to consider? Well, I'm excited because these authors said it's time to consider quality of life measures. It's time to consider the quality of prevention. That's right. Not just CAUTI, CLABSI, and all the other things where there's economics involved, but it's time for us to look at issues that make sense to our members for sure. And the authors in this July 27th paper called for greater transparency. Finally, I think this paper was also really important for our movement because it points out the terrible disparities and inequalities in access to care ought to be part of the quality measurement. Let's make sure everybody understands this. I think this is powerful, and I hope we'll come back to this throughout the 4 days of the ACMQ meeting, whereby the social determinants all need to be important. Okay, the fifth paper is the National Quality Forum, and I know that our colleague Shantanu Agarwal is one of the speakers this week, which is fantastic, and Shantanu's done a great job at the National Quality Forum. But their report, The Care We Need, I hope you all download it and read it. An amazing, amazing paper. What does the NQF report, The Care We Need, which came out just a month ago, what does it say? Well, first of all, it had a cast of hundreds of all the pundits in our field, an amazing collection of people led by Shantanu. And this report basically looked at patient stories, patients telling their own quality and safety and lack of care coordination, and nobody talks to me and my doctors don't talk to each other. Here we are in 2020, and what do we hear back from patients? The same thing we've been hearing since crossing the quality chasm was first published. We don't talk to each other. There's no transparency. We don't coordinate. It's all about following through on the pernicious incentives of RVU-based payment. I thought the NQF series of patient stories was really compelling. Some of it was honestly gut-wrenchingly difficult to read. But the conclusion of The Care We Need says, well, we've, quote, demonstrated some overall improvement. Well, you know, I'm a real fan of the NQF. We've demonstrated some overall improvement. Boy, that's damning praise if I've ever heard it. So look, we have a long way to go, and I think it's really, really important that everybody read this great report, The Care We Need, just a month ago from the NQF. That's our 5th hit paper. Okay, couple more. The 6th paper, which I was amazed to see in the New England Journal, August 6th, from our colleagues Don Berwick and Chris Castle, 2 giants in our field, was a review of the role of the National Academy of Medicine, of course, formerly the Institute of Medicine, now the National Academy of Medicine. So what did Don Berwick and Chris Castle say? Well, they did a deep dive on the history of the National Academy of Medicine, its role in helping to co-promote ARC, its role, of course, in publishing Two Errors Human and Crossing the Quality Chasm. And the punchline, not surprisingly, because Don Berwick was involved, let me give you the punchline, August 6, 2020, our 6th paper, reducing waste is the key. And you and I know that when we say reducing waste, waste has many components, error is a sub-component of waste. So reducing waste is still, here we are in August 2020, still our most important strategy. And that, according to Berwick and Castle, quote, the rhetoric on improving outcomes still outpaces actual progress. One more time, the rhetoric on improvement outpaces actual progress. And I would say to that, regrettably, amen. So on the impact on quality in the post-COVID digital world, we have a lot of work to do. What I was a little surprised about was Don Berwick and Chris Castle, once again, are calling for a federal oversight agency for quality and safety. So this is not a new topic, and our colleague Peter Pronovost wrote about an SEC for quality more than a decade ago. But I thought it was very interesting in this really important New England Journal of Medicine piece 3 weeks ago by 2 of our biggest leaders, looking at the history of the National Academy of Medicine, they're calling for a federal oversight agency. Okay, 2 things to go. So one was the August 9th issue of the New York Times Magazine, the Sunday New York Times. I hope you saw it. An incredible piece outlining the struggle between doctors on the front line at Northwell and doctors behind the scenes at Northwell in charge of doing randomized controlled trials for different COVID-19 therapies. So again, docs on the front line, docs behind the scenes running the trials, and the tension that these 2 groups of doctors had with one another, I think is very important in the digital world moving forward. The tension was focused on, look, the folks at the bedside said, we're here struggling to save lives. The folks behind the scenes said, we're here to produce good science that everybody can rely on, so don't mess with our protocol in the randomized controlled trials. Wow, that's really amazing. So we're going to have to talk about in the digital era, when we have digital trials, how will they be welcomed or not, I think is a really important thing. And then finally, late August, just a week or so ago, from ACMQ, telediagnosis for acute care. One more time, telediagnosis for acute care. This final paper I thought was amazing from ACMQ, and it points out something I've been saying for 2 years now, which is while our incredible telehealth colleagues ramped up and clearly connected with hundreds of millions of patients during the pandemic, what we're not paying attention to, in my view, what are the outcome measures from telehealth? And I don't like to call it telemedicine. I much prefer digital health. From the entire digital health, what are the outcome measures we're going to be looking at post-COVID surge? So again, to follow the IOQ nomenclature that Don has so interestingly set up, what's the impact on quality going to be with telediagnosis? In other words, when you have thousands of doctors online seeing tens of thousands or even more patients, how do we know who's doing a good job and who isn't? How do we close that feedback loop? So let me review. All I tried to do, colleagues, was go through 8 papers since the pandemic that I thought had implications for the listeners and the learners in our community of folks who care a lot about quality and safety. A lot has happened. I haven't talked about the untold burden of care while we were closed. I haven't talked about the fact that CMS delayed reporting of all quality measures for another 6 months. I haven't talked about any aspect of that, these are big topics too. What I tried to do was use the published evidence to say, wow, we have some real challenges as it relates to care in the post-COVID digital world, and I've tried to outline some of those challenges. So let me close in my prepared remarks, no PowerPoint, because nobody wants to watch PowerPoint in August. If they want to just listen, get a couple of take-home messages. Let me close by saying once again, what a privilege it is for me, a longtime member, your editor-in-chief of the journal, to be engaged with you and my colleagues and with Don and the leadership of ACMQ. A true privilege, and we ought to be feeling pretty darn lucky that we have the opportunity to continue our work during this time truly of a national healthcare quality challenge. So thanks again, and looking forward to seeing and talking with Mary and with Don.
Well, thank you, David. And Dan and I are going to kick off with some questions to you in just a few minutes. We already have 5 questions in the question box that we are going to tee up. Those are the ones that you don't even know about. Of course, we have a bunch of planned questions as well, but I just want to address a couple of things that have come through the chat box. The first one that David already responded to is there are no PowerPoints during this presentation. It is a conversation among all of us, and we hope among all of you as well. So please put your questions in the chat, in the not the chat box, in the Q&A, and we'll respond to them. As well, people have asked for the references that you've used, David. So
sure,
we'll put those together and we'll send those out via the ACMQ listserv that's associated with the conference, so that you have an opportunity to read the articles yourself and move forward as we go forward. So I'm going to turn it over to Dan. I'm Mary Cooper. Of course, that's evidence, since I'm the only woman that among the 3 of us. I'm Mary Cooper. I've actually worked with David at Jefferson for the past 5 years and have known David for 30 years as I've pursued my career in healthcare quality and safety. I'm the Chief Quality Officer of the Connecticut Hospital Association right now, and I run the program at Jefferson. And we're just so excited to be here, both of us, all of us, and so excited to see so many people signing in remotely. And so thank you so much for joining us. I'm going to turn it over to Dan to introduce himself a little bit more and also to ask the first questions. And then I'll pull up the questions from the question box as Dan is introducing himself and teeing us up.
Good afternoon or good morning, whichever time zone that you happen to be in. It's great to be with my good friend and longtime associate, David Nash, whom I've known for 15 or 20 years, being on the editorial board of the ACMQ and being part of the ACMQ, and also with Don and my new acquaintance, Mary, who we've gotten to know over the last several months and helped me put these questions together. I helped her put the questions together, I should say. But David, I think there's a lot of information that you put forth and a lot of questions. And I would like to kick this off by asking this question. With current controversies in the literature regarding findings related to COVID-19 treatment, social distancing and isolation, among others, where and how do we start the quality measurement process in the virtual world? And what will be our initial focus?
Wow, well, talk about starting with a tough question. So thanks again. Yeah, so look, as we sort of alluded to, not all care is going to be remote. We know that if you look at Jefferson Health, the 14 hospital system that I've been a part of now for 30 years, we're almost back to pre-COVID face-to-face utilization levels. We have more to say about that later. So I think, as I tried to note, distilling those 8 papers, where I see we're going, we really need to reduce the measurement burden. So I think one take home from your great question Dan, is let's reduce the measurement burden and let's measure stuff that matters, because our members know you're only going to improve what you measure. So you better measure some stuff that's important, because that's where the energy and the resources are going to go. So look, we're still also facing the pernicious incentives around the country in most places still of a RVU-based, mostly fee-for-service. The more we do, the more we get paid. I mean, what will it take for us to finally embrace the idea that nothing good is going to come from a pay-as-you-go system? I mean, here's another way I'd answer your great question. For all of our listeners, let's be provocative. You know, raise your hand if you think the system, the healthcare system that brought us to the brink of collapse clinically is the same system we need to take us into the digital future that Don Casey described. I mean, you know, if you think this system is the one for the future, you're in the wrong meeting. So, summary, fewer measures that make sense, measures that are transparent, reproducible, valid, have implications at the bedside, both in the office and in the hospital. We have a lot of work to do. I don't think this is a really critical time for our movement. No more check the box, no more super reliance on process measures. And I would add, based on the review of those 8 articles, let's think about those social determinants, equity, and measures that make sense to the disenfranchised.
Great. Thank you very much. Kind of melding into that same theme, David, is the next question. With increasing focus on virtual health, how do we capture and leverage quality data with improvements such as tracking some of the quality of life measures that you talked about, such as homebound patients with cognitive dysfunction, and also those that have limited function, so to speak. So I'd like to hear more about it. Thank you.
Yeah, that's really tough. We know that many elderly, and remember, I'm 2 months away from Medicare now, so, you know, I get it. Many elderly are not digitally proficient. Certainly folks with disabilities or functional limitation. We assume, you know, everybody's on this conference is digitally enabled, some better than others. And, you know, I don't have my 29-year-old son here to help me as a technical consultant. But look, I think we're going to need maybe different kinds of measures for folks who don't have this sort of access. It's a real challenge for our field. I mean, even recognizing that there are large populations who don't have access to care and populations who have encumbered or burdened access, not straightforward. And then how do we have measures that make sense for them? Yeah, I think that's a real challenge. I don't have a great answer to that question. How do we help these people right now? Unfortunately, I think they're still going to be on the penumbra, on the fringe. We have such work to do in the core to create measures that are reproducible, valid, make sense, have a clinical impact. I'm worried that your question is not answerable currently. Yeah, quite frankly.
David, thank you for both of those. And Dan, thank you for both of those questions and the answers. I do think that we have a number of questions that are coming from the audience. So I'm going to move away from some of the questions that were posed by the two of us to you when we were having our discussion preparing for this, because there's so much to talk about. And so first, from John Matulis, are there any trends in value-based payment which can level the playing field for smaller practices and healthcare systems?
Smaller practices. Okay, yikes. Yeah, I'm not sure exactly what that means. You know, what's a small practice? I don't know.
Rural.
You know, rural. Okay, well, look, we want to have a level playing field, and we want, as a system, I would believe, to have certain, you know, minimum quality and safety standards. Certainly, we would all agree, no matter what, is do no harm. Care is never going to be error-free. Care must be, wherever we are, harm-free. So I don't care if you're in a 2-3 person practice in a 10-bed hospital, your sworn duty is still to do no harm and have care that is harm-free. So size, all of that, I guess, is important. But I think that I'm back to my central tenet, Mary. We need measures that make sense, and we need measures that close the gap and that are, in the jargon, actionable. But let me give you some examples of what I mean. I think most doctors today and our nurse colleagues and our pharmacy colleagues, it's not just for doctors. Most folks who are taking care of patients in a team setting want measures that are going to help them to do a better job. I mean, I can't imagine anybody would go to work thinking, I'm perfect and don't close the feedback loop with me. The analogy I would make is, if you give somebody a fish and they're hungry, they'll eat the fish and they'll be less hungry. It's much more complicated to, as the saying goes, teach them how to fish. So the analogy that I'm trying to make here is, let's spread our gospel of improvement and evaluation. Let's take the STEEP, STEEP framework forward, deeper into the 21st century, still makes sense. And let's think about those issues of equity and access that we really, quite frankly, didn't pay too much attention to pre-COVID. So I don't really think size is the issue. I still think the issue, as I see it, is what are measures that make sense? Okay, now let's deal with the size. So I guess what I'm hearing in this question is, does a 4-person practice need to meet the same criteria as, Jefferson Health? Well, that's a tough question. If you're in a value-based system and you're going to get paid, at least in part, on the outcomes, then I would have to think that a small practice is going to be held to many of the same high standards as a larger practice, whatever we mean by that, will. I hope that these distinctions go away. I don't really buy this. I think what I'm after is, as we move towards value-based payment, and Mary, in our college, for a decade, we've been talking about, here it comes, right? No outcome, no income. Let's do it again. No outcome, no income. Now that's a little harsh. So, gradations in outcome equal gradations in income. That's where the world must go to reduce waste and to improve outcome. If your 4-person group doesn't have the technology or the wherewithal or the ability to close the feedback loop, well, then that's going to be a gigantic challenge for a small group, however we define it, to participate in the value-based payment, evolution. Are we there yet? Probably not, but I think we've made gigantic progress. And maybe we could come back to, where's value-based payment going in the post-COVID world? I think that's another important question. It's a long answer to a tough question, but size ought not to matter. I think that's my take home.
And in fact, we're going to come back to some questions that are posed about MIPS a little bit later on, which is as many of you know, provider-based quality measurement system. But before we go on to that, I do just want to point out coming in the fall is Task Order 3 from the federal government, which is focused on rural hospitals, on vulnerable health and vulnerable hospitals and vulnerable patients. And so maybe we'll start to see some of the measures emerge in that area as well. The second question before I turn it back to Dan is, David, what do you think is the role of artificial intelligence and machine learning in helping to determine the measures that actually have clinical impact and help improve the health outcomes of the population, from your colleague, John Vigorita?
Wow. Yeah, well, great that John is thinking about these issues, and I'm not an expert, but we've spent as a college, as Mary knows, an awful lot of time and energy on the future of AI and machine learning. So we've created in our college the population health intelligence as our term to sort of subsume artificial intelligence, machine learning, augmented intelligence, artificial reality, the whole growth area. So I think we're going to see unprecedented attention to the power of AI to go through data sets and to glean learnings that no individual or group of individual doctors could ever help to do. So we're working with a number of private sector companies, global companies, even looking at how do we harness the power of AI to go through these data sets and to bring out implications and connections that we could never figure out on our own. So speaking personally, I'm very excited about the role of artificial intelligence as it relates to improvements in outcome. Therefore, it will give us insight into what we ought to be measuring. So another thread that I think is very interesting here is how will AI affect the creation and dissemination of new measures? Well, I think that's very exciting. And I hope it will create measures that make more sense at the bedside, have a greater impact on outcome, and are not solely process focused. So, great question. There's a lot of power here. Let me mention some of the companies in case our listeners are interested, and some of these work directly with Jefferson Health. Among them is MD Clone out of Tel Aviv, Israel, amazing Israeli company with a research base in Tel Aviv. So they are able to create synthetic data, so suck information out of your EMR, totally de-identify it, make it available for health services research. They have an entire AI suite. Innovacer, another amazing company based in San Francisco, enabling us to close gaps and provide information that's actionable. There's an AI component there. Virtually every information technology company, whether they're working with Jefferson or not, is got an AI focus. So I am very excited about the potential here. It's a great question. And I bet in future, future ACMQ meetings, we'll be talking more and more about the AI-enabled measurement machinery. I mean, that's going to be amazing. And I'm pretty confident. And I just hope I'm around to see it. And I'm excited about what the opportunities are.
Don Casey reminds us that we'll be dealing more with AI and machine learning in session 2 with John Rucker later today, in session 5 with Blackford Middleton on.
Well, you've got Rucker at Middleton. You got two of the giants, which is really great. And both Don and Bradford have been real partners with ACMQ over a long period of time. So great. They know a hell of a lot more than Nash does about the role of AI. But big picture, that's my job. You heard it here. More and more of these tools are going to be used all the time. And I think it's going to be transformative.
And then, of course, before I turn it over to Dan, I just want to remind everyone that we as helpful arbiters of quality and safety have to always be looking at who's writing the algorithms for all these big databases, because as we know, the algorithms themselves, whether they're guiding your Netflix purchases or rentals, or whether they're guiding the algorithms that provide care to individuals, if they're not written so they're unbiased, if they're not written so that they're looking for the appropriate outcome, they can get us into trouble themselves. Dan, can I turn it back to you?
Sure, thanks, Mary. Yeah, we have a really good question from John Wendell, and I'll just read what his question asked. It seems like Berwick is advocating top-down solutions. Gawande, however, has written the biggest impact in instituting the checklist manifesto came for local ownership and involvement. How do you rectify those two perspectives?
Yeah, wow. Yeah, I I can't, I really can't modify the two perspectives. How do I reconcile them? Here's my attempt. Okay, so I think I was surprised that Don Berwick and Chris Castle, two of our longtime leaders, are still, less than a month ago, still calling for a federal agency to be responsible for promoting, measuring, collecting quality and safety data. Now, I'm not saying one way or another what my personal position is. I was surprised for calling for this. And the reason I think that Don and Chris are doing this is because of modest progress, as pointed out in the NQF report that you're going to hear more about with Shantanu. In other words, look, let's not kid ourselves. We have had modest progress. So an outside observer looking in on our field might say, well, time for a different playbook because we've only made modest progress. Let's call it the last 2 decades since 2 errors human and crossing the quality chasm. So that's one really powerful view. We know on the ground, however, that all improvement is, individual, then a collection of doctors, and then closing the feedback loop and remeasuring and doing the PDCA cycles. I don't think that they're irreconcilable. In fact, I think they're very compatible. Here's how I would put it, maybe a different way. At the bedside, wherever we are, office or hospital, doesn't matter, or online, the individual commitment to self-evaluation and measurement is still there. Whether all of that collectively will get us to national goals on quality and safety, that's another challenge. So we got to do both. I think it's complicated. I don't think lots of people would agree, regrettably, with Don and Chris about a national effort. I think people see this as, our sworn duty to measure, evaluate, improve, do no harm, reduce waste. Our tune has not changed in 20 years. Our progress has not been great. So are they reconcilable? Sure they are. We still need to do hard work at the bedside. And at the national level, we still have to prove that we're getting a return on our $3.5 trillion investment in healthcare. I mean, it's a big topic. So it's a great question, really great question. Is it reconcilable? I think so. Because they're asking 2 different questions. One, work at the bedside, and then policy work at the national level.
Okay, we are going to end the webinar here. We still do have about 27 minutes of the video, but to avoid from going over that 1 o'clock time limit, we will be sending out this video recording to everyone who did attend, and we will also send out all the information you need in order to claim your CME credit. But thank you again for your time, and with that, have a great rest of your day.